Ladies and gentlemen, Chris Zalewski.
Thanks, Andy, for that warm welcome. And I got to say, I'm just taken aback and really duly impressed by everybody here. What a great family foundation and just really warm group of individuals. I have seen many of your children, and dare I say, I love them dearly. Really, really wonderful group of kids. So I'm going to ask you to lend me your ear, pun intended, and I'm going to talk to you about probably a little bit lesser maybe concern for Smith-Lemli-Opitz, and that's hearing. But I think after this, maybe I impart upon you a little bit greater of a concern, and we're going to get through some of that as we talk about the understandings and basic, just really simple anatomy and physiology of the ear. And we'll move into then what is the hearing phenotype in Smith-Lemli-Opitz and the impact of that hearing loss, if there is some. Potentials and solutions to some hearing loss, if some exists. And then certainly challenges with hearing management, which I think we all agree with some of those challenges in this group. So simply the ear is composed of what we'd like to think of four basic parts. You have the outer ear, the middle ear in green, the inner ear in red, and then the auditory nerve or the central part of that pathway in blue. And if we started with the outer ear, it's generally what we see. It's the pinna, which is that lobe which we love to hang earrings on and things of that nature. Doesn't really do much except help us localize and kind of funnel sound into the ear. But it also includes the ear canal, which in and by itself isn't really that big of an issue, with the exception of that sometimes it likes to collect things either placed there artificially or made by ourselves, which would be composed of wax. A lot of people just kind of ask, what should we do about wax? And this is the first part of our exam. We actually try to look into your children's ears, and sometimes that's where the exam stops too. And I can appreciate and recognize that, so we'll talk about other alternatives for that. But other times, certainly we have cerumen and wax buildup, and that can often be not a problem at all unless it impacts and totally impedes the ear canal, which then it has to be removed. Yes, true, it's probably a very unlikely thing that we could do that awake, but you can easily do that during sedation, which we see many times for our children. And that can be done effectively, and it's really not big of a problem. So I'm going to move on from outer ear and go into the middle ear, which is where I think we find most of our difficulty and our challenges and our problems in Smith-Lemli-Opitz. It's composed largely of three middle ear bones and the eardrum itself. And really, it's just a mechanical amplifier. Sound kind of hits that eardrum. The eardrum vibrates back and forth, and those vibrations are transferred through those three bones. I think at school we called them the hammer, the anvil, and the stirrup, and that's fine. You can call them those. But those vibrations are carried into and vibrate against our inner ear, also known as the cochlea, where all the kind of magic happens, and we transduce sound, and we actually pass that along to the brain. But for the most part, the middle ear is problematic because it likes to actually have a lot of infections associated with it, and a lot of times those occur because of an abnormal eustachian tube. And the eustachian tube is just simply a pathway, a funnel or a tube, if you will, that connects our middle ear space, which is normally air-filled, to our throat. And we, a couple of hundred times a day, re-aerate the air in the middle ear by kind of bringing air through our throat and aerate and re-aerate the middle ear space. And we all probably, not all of us, some of us drove perhaps, but when you fly and you have to pop your ears as you're going up into the airline, what you're doing is forcing the eustachian tube opening and then just re-aerating the middle ear space. Because if you don't, there's this kind of difference between the pressure gradient of the middle ear space versus the outer ear space. And what happens is due to developmental defects or even sinus infections or allergies, sometimes the functioning of that eustachian tube can actually be problematic. And if it becomes problematic, it tends to close up a little bit. And if it closes up a little bit, it can't re-aerate that middle ear space. And if it can't re-aerate that middle ear space becomes more and more and more and more negative pressure related to the outside pressure of the ambient. So what's the body's natural defense against that? Well, of course, it's to produce fluid. Think of these cells that outline the kind of middle ear space. They're called air cells, and they like to eat air. So when there's no more air in there because it's not being aerated, think of them as crying. So when they cry, they produce this middle ear fluid, and lo and behold, you have fluid in the ear. It's not yet infected, but you still have fluid in the ear, which fill any snare drum up with fluid, and it ain't gonna sound the same, right? So that conduction of that mechanical transmission of vibrations to the inner ear is gonna be disrupted. So we develop a conductive hearing loss. Now, one of the options for this, of course, all this fluid that we have in the middle ear space that we've created, is to insert a tube. And that tube allows an alternative of the closed eustachian tube, and also a way for that fluid to drain out. And once the fluid drains out, it provides a new way by which we can aerate that middle ear space. Now why do Smith-Lemli-Opitz children have this problem? In large part, and I'll show you a picture a little bit later, is because their eustachian tube probably doesn't function quite as well as it should, simply because of the orientation of the eustachian tube itself. It's a little bit more horizontal in nature than adults. And there may be some problems with the muscles that actually control the eustachian tube as well. But I'm going to move on from the middle ear and go to the inner ear. The inner ear is composed of the cochlea, which is this snail portion, and this fin portion here is the vestibular system, which we're not going to talk about today. This coiled snail part is the cochlea responsible for hearing and responsible for sound processing. So when those vibrations are placed against this snail portion, those vibrations are funneled along this snail tube that's filled with water and has thousands and thousands of hair cells that sense those vibrations. The hair cells move in response to those vibrations, tickle the nerve, our nerve tells our brain, and voila, we hear sound. So if the vibrations are not being transferred through as well as they should, maybe those cochlea, those hair cells are not going to transduce that sound as well as it should as well. There's also another problem that can happen, certainly, is all of those hair cells can have, well, they can have disease and problems and damage associated with them as well. Most often, we think of those diseases and as damaging related to either noise, excessive noise, age-related, those hair cells begin to die off, but they can also occur because of genetics. I'm not going to suggest that sensory neural hearing loss or the loss of some of these hair cells is prominent in Smith-Lemli-Opitz. It's not. It is a little bit, and we'll get into how much it is present. But for the most part, the cochlea is responsible for the transduction of sound through these wonderful hair cells. And unfortunately, ask any bald man that is, what happens to a dead hair cell? It doesn't tend to grow back. So these don't tend to grow back, so these loss of hair cells or sensory neural or cochlear hearing loss tends to be more permanent in nature. So when we set out with this project in about 2015 or 2016, we published this paper about 7 years-ish later in 2022, really kind of denoting or describing the auditory phenotype in Smith-Lemli-Opitz. That's the paper there that if you just wanted to download it there, you can. And this is the large portion, is the paper that I'm going to present, the data that I'm going to present to you here today. So in audiologic testing, that's my daughter when she was about 6, so I figured I'd throw her in just because it's a family conference. We can either do hearing testing one of two ways. We can do it either awake or sedated. And if we do it awake, we have a lot of different techniques by which we can use. We can use the old traditional hand raise when you hear the tone. We can play games with the child. We can even use, and it's right behind Keisha's head here, there are some animated toys that they can respond to in the sound field. It's all developmentally age-appropriate testing at which we try to measure the hearing sensitivity of your children in response to various really super boring pure tones. So we can do as much as we can awake, but we also test them while they're sedated if that's appropriate. There are a couple of different things that we do during sedation. One, we look at the health of the auditory nerve itself, including some of the brainstem, and we can also look at some of the hearing sensitivity. If some of your children aren't able to respond to those wonderful, boring pure tones in the sound field behaviorally awake, we can actually measure how sensitive they can respond to some of those tones while they're sedated. It is certainly not the gold standard. The gold standard is that of the behavioral evaluation, hands down. Hands down. When we determine sensitivity via sedation, it is more, shall I say, an estimation. It's a pretty good estimation, but it's still an estimation or a prediction of hearing sensitivity. And that estimation or prediction power is not quite as good the better the hearing. And we'll get to why that's a problem, because if you have normal hearing, you could actually suggest there's a slight hearing loss. So the predictive nature suffers a little bit when the hearing is a little bit better. But the algorithms are continuing to work on that. So let's talk about some of the data that we obtained when we were able to test them either awake or sedated. So this was the cohort that we had between 2016 and 2022. It encompassed 32 individuals, 3 of which were outside records, about 68 visits. So we do have some longitudinal data in here that'll show you a little brief snapshot of. A little bit more males, and here's the age of each as well as the total group. So the mean of the age is about 9 per se, and most of the time with the data, the gold standard data was via that sound field evaluation. Over the last, since 2022 or 21, since we stopped collecting data to report on our manuscript, we collected have collected about another 16 patients. So right now, as of this week, we've collected about 48 patients, which raised our mean age up about 3 years of age to just under 12. So 16 more patients, 50% more recruitment. Maybe it's time to relook at it, considering we do have a little bit more older subjects in there as well. So for the most part, we do, and this data will support behavioral evaluations, but we also include that which we get from the auditory nerve or the wonderful hair cells, some additional tests that we can do. And I highlighted this yellow section here because this is what I call the challenging section. Not only challenging behaviorally, but also you have to find out what works for the child. And this is true of anyone. This is true of even normal developing children. A child who's 3 years of age, they may not want any part of this as much as a child of 3 years of age who has a Smith-Lemli-Opitz as well. But you can see is the amount of patients that we do have in the pediatric zone there, I should say, that makes some of this testing a little bit challenging. So otologic, what is the snapshot there? So about 34 to, just round it at about 35% have posteriorly rotated ears. So what is that? So the ear is just a little bit low set and it's a little bit posteriorly rotated. Why is that a big deal? Because it changes the orientation of that eustachian tube. Remember? The eustachian tube then becomes a little bit more horizontal, it becomes less efficient perhaps, and therefore if it's less efficient, this is why there's recurrent otitis media or ear infections in this group of individuals. And this becomes the problem of recurrent otitis media in 63%, and then pressure equalization tubes are placed in about 41% of our cohort. Now, recurrent otitis media is about 30 to 40% in the population, so we have a little bit more frequency of that, shall we just call them ear infections, than you would normally expect. It's probably more similar to that of the 53% in the normal population that you see for cleft palate, which tends to make sense in our group as well, since that's a concurrent symptom or prevalence as well. Lastly, and that I have that image there for that, and then there's a low incidence of hyperacusis, and I wanted to touch on that because I think that there is a concern for hyperacusis, and we just saw a patient who has kind of a problem with this, and so this is difficult to deconflate across patient groups. Hyperacusis is sensitivity to loud sounds. Now, there's about a 17 to 20% normal occurrence of hyperacusis in children. And that's normal. So kids don't tend to like firecrackers, sirens, things of that nature. There are groups like Williams syndrome and Smith-Magenis syndrome that have a high prevalence of this. Now, we noted a low incidence of hyperacusis at Smith-Lemli-Opitz, but I don't know if we need to revisit this or not. So it's a good question. The hearing snapshot, then, we're going to move away from some of these otologic, but more so towards audiometry and talk about the hearing evaluations itself. We're going to touch briefly on the longitudinal aspect of hearing over the lifespan or the pediatric lifespan, but our sample size is super small on that. So what are the hearing results? Well, first, let me just orient everyone to how we measure hearing and how we discuss hearing. So hearing in itself is plotted on a chart which we call an audiogram. On the x-axis up top here is pitch, what we call frequency. Like a piano, it goes from low pitch to high pitch. Okay? Now, a piano goes from about 27 hertz to about 6,200 hertz. So we're right about there. So low pitch to high pitch. And the y-axis is volume, which we like to call intensity. Really soft sounds up top, really super loud sounds on the bottom, and think of that as a volume dial. So what we tend to do is in normal conversational speech occurs at about a mild to moderate volume level on the audiogram itself. So when we plot hearing results, we plot right ear and left ear using a red 0 or a blue X. And we plot the softest level at which anyone is able to hear an individual pitch. So at 1,000 hertz or 1,000 hertz pitch, how loud do I have to turn the volume dial up for you to just barely detect it? Think of a piano. How lightly can I tap on the key and have you still detect it? Well, if you can detect it anywhere from about 0 to about 15 decibels. We call that normal hearing. And then we have these gradations of levels of hearing impairment after that or above that. So if I had to turn the volume dial up to, say, 30 decibels, I would call that a mild hearing impairment because I had to elevate my volume dial up to the 30 clicks before that person could barely detect the presence. We have the same thing for the left ear. Commonly, they're the same. They're very similar. They don't have to be. So again, we can describe hearing at relative frequencies. So when people ask me, well, how much hearing do I have? Well, that's a difficult question to answer because it differs depending upon what frequency I'm going to tell you. For the low frequencies, your hearing is normal. For the mid-frequencies, you have a mild to a moderate hearing loss. For the high frequencies, you can even have a severe hearing loss. So the degree of hearing impairment depends on whatever pitch I'm playing. We can take an average of sorts, and we do, and sometimes we report that in papers to make it more simple. But just to say that, oh, well, you have a mild hearing loss,
Well, it only tells you part of the story because, true, overall, on average, you might have a mild impairment, but that kind of hides the fact that you have normal hearing for the low pitches and severe hearing for the high pitches. So it can get a little bit complicated. So what we can do then is we can describe the hearing loss in Smith-Lemli-Opitz. So drum roll, and this is the data that we came up with. And two things about this. Number one, the average hearing in Smith-Lemli-Opitz is a slight to a mild hearing loss. The average across almost the entire frequency range. The other thing that I would point you to, though, are these lines describe the overall variance of the group, which means that a lot of kids have normal hearing and some kids have a little bit more moderate hearing loss. So even though the average of the group is slight to mild in impairment, there is a very big range of hearing loss impairment. So what we can do is, I'll just kind of show you the entire group. And we'll make this a little bit more complicated, but we can understand this now. And each color represents a different patient. So you can see you see a lot of patients here that actually have good normal hearing. Fantastic. And this is why I think this is probably less of a concern of a symptom, but I want to impart upon you that at times you can also have a slight to a mild hearing loss, and I will show you some data as to why that is concerning, or perhaps we should pay a little bit more attention to that. So you can see that about 56% of our individuals had some degree of hearing loss, most having a slight to a mild hearing loss, with a very few having more of a severe to profound impairment. Now, I will tell you that when we talk about, well, where is this hearing loss? Because we talked about hearing loss occurring because of a middle ear problem with those bones and fluid in the ear. We also talked about hearing loss being a problem within the cochlea, those hair cells. I will tell you that the majority of the problem of these hearing loss individuals here is more conductive in nature. It's more fluid related, ear infection related. I will tell you that these patients down here were sensory neural related. Now, two of them did not pass, and there's 3 individuals here. 2 of them did not pass a newborn hearing screening. So they were congenital in nature. Now, am I going to immediately assign that to Smith-Lemli-Opitz? I'm not. I think it's fair that you probably should check other non-syndromic or especially non-syndromic. There's a very, 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 very common non-syndromic sensory neural hearing loss of severe degree. It's called connexin. And that probably should be included whenever you have some severe or profound hearing loss. The third individual here did pass a newborn hearing screening, but had a progressive loss of hearing that I think reached the severe to profound level by, I think, about age 8. Again, hesitant to assign that directly to Smith-Lemli-Opitz. So where is the hearing problem? Well, for the most part, we have a large conductive middle ear pathology, which is, again, a problem with probably fluid in the middle ear related to an obstruction of those, how well the sound is transferred through the vibrations of those bones, like the fluid-filled snare drum. It's just not going to sound very good. And then there are some sensory neural pathologies. About 35% did have some problem with cochlear hearing loss. There was an earlier report that suggested it may be around 10%, and we're certainly kind of denoting a higher percent of that at about 35%. And then mixed can actually occur in both locations. I will say with those with sensory neural hearing loss down here, they were largely profound in nature, and again, 2 of them likely congenital or they were born with that. Again, hesitant to call that Smith-Lemli-Opitz. So what about progression? Because I think everyone's interested about, hey, does this hearing loss get worse? For the most part, conductive hearing losses, they don't necessarily get worse. They can, but they reach a certain limit, and then we tend to treat them with either tubes, or we find out what the problem is. If it's fluid, drain the fluid. So these may tend to be somewhat temporary, but not necessarily. But what we have are 4 patients that we looked at progressive over time. Now, most of them just do not progress over time, largely because conductive hearing losses, as I said, don't necessarily progress. There is one individual that did show some progression. Now, I don't want to have any alarm here. This was a progression of those higher pitches, like 6,000 or 8,000 hertz, really high pitches. But it was still unique that we did see this progression of hearing loss for these higher pitches. We usually see that in age, but certainly this is a largely pediatric group. So we are yet to have any really kind of conclusive etiology as to why we saw a high frequency progressive nature of that hearing loss, but I do want just to impart upon you that for the most part, and again, small sample size 4, we don't necessarily see a large progression in those patients. So I ask you, what is the impact of a slight to a mild hearing loss, okay? You just say, well, it's a slight hearing loss, not a big deal, right? Okay, well, a slight to a mild, and I know this chart is lacking the word slight, but we'll just include that into that because it's about 26 to 40, which is about what our range was as well. And they have difficulty hearing soft sounds and may struggle in noisy environments. We're like, okay, well, the thing about hearing a soft sound is that if you hear school, you can still make out I probably said school, right? You heard it. You heard it soft, but you still heard it. So your brain still processed the information. So people are like, well, they're still hearing the information, right? Well, that's fine if you talk about adults, but I don't think that always is. I think it's more concerning when we talk about children, particularly those children that have this grouping here of slight to mild hearing loss. So I steal some data from, it's an old but landmark study that looked at this is normal hearing children, 20 normal hearing children, okay? And everybody struggles in noise, right? So this is test condition. This is quiet, okay? Like we're in this room right here. Now, this is where my voice is 6 decibels louder than any noise that might be in the environment here. So my voice is louder than the noise in here. So when it's plus, the speech is louder. And by the time we get to -6, this means my speech is 6 decibels lower than the noise. So if I had Michael just introduce some noise and made it 6 decibels above my speech level here, well, everybody tends to suffer a little bit in their speech discrimination ability, even normal hearing individuals. We notice that when we go out to a noisy restaurant. We all don't do very well. But what about slight to mild hearing losses? Do you think they decrement the same way? Well, they don't. And in fact, this is children. And mind you, adults can often modify how they perceive language and conversation. Children necessarily can't. So by the time that they are in a somewhat noisy environment, they're doing actually quite poor. Slight hearing loss. Why? Because, well, children can't really adapt and really respond well and have the flexibility of mental capacity to change, hey, did you comb your hair today? What if I said, hey, did you comb your bear today? Okay, you and I might think, well, did he say bear? Or did he say hair? He probably said hair because my mental flexibility is going to change that. But no, when I was talking to my daughter, I was like, hey, did you comb your bear today? Because she's really into combing her bear when she was young. But children may not necessarily have that mental flexibility, so in noisy environments, they really do tend to suffer quite a bit more than normal hearing children as well. This is another study that has some relevance. It was done with Down syndrome children, 20 Down syndrome children, and this is just picture pointing. Out of 10 pictures on a page, can you point to the bear? And when the noise level is 10 decibels less than my level, they did pretty well. But when the noise level was the same as my speech level, they actually did pretty poor. Meaning, and these are children with slight to mild fluctuating hearing losses. Why fluctuating? Because middle ear infections fluctuate. Sometimes they get better, sometimes they get worse. So what's the answer here? The answer are for some solutions would be that of, kind of reintroducing a louder signal to their environment, right? Now we can do that a couple of different ways. We can do that via hearing aids, which has its own problems, and then everybody hears about over-the-counter hearing aids, but then we'll talk about assistive listening devices. Now hearing aids, is that a good option? It probably is not, for a couple of different reasons. One, the hearing loss does tend to fluctuate. When you don't necessarily have an ear infection, you may not necessarily have a slight to mild hearing loss. And ear infections vary over time. Now, recurrent middle ear infections, however, could be another problem. Because are you having one ear infection over 8 months or 3 over 8 months? It's still recurrent, it's still a slight to mild hearing loss. So what happens is, it's also, will the patients tolerate a hearing loss? Hi, Juki. So will the patients tolerate even hearing aids? Some maybe not. So benefit is always going to be personal, and it's always going to be based on the individual, and we all know the individuals of our children. So for anyone that's saying, well, what about over-the-counter hearing aids? Really tough to have that conversation because, for one, hearing aids should be, especially in an environment such as, well, in a cohort such as ours, the fit should be probably very professionally assessed. And they should be verified to say, yes, they're appropriate, no, they're not appropriate for the child. Over-the-counter hearing aids do not offer that. They're often self-fit programs. They are designed for a slight to mild hearing loss, but again, the lack of verification, the lack of, they have to be self-fit, they're not an option. So when you hear discussions about over-the-counter hearing aids, I would not put them in the discussion of what something of our group of people should be considering. This is probably a really nice alternative. And this is what we say some things as assistive amplifiers. It's personal alternative. This is a QR code for this device here made by Phonak. And a lot of times you have these and you see these deployed in classrooms. We actually have 2 here today. And they're to your left. You're to my left, your right. And those speakers are flooding the environment such that the people in the back are hearing my voice as easily as the people in the front. And now think of this as a classroom, because not only distance but noise has a decrement on how well we perceive speech. But if you can flood the environment with sound and with the intended speech, well, you also have a group, and the benefit is often broad in nature. It actually has a positive impact for everyone. And guess what? When you look at data, when you look at supporting results that look at how good is sound field amplification, guess who benefits as well? Normal hearing individuals as well as high achievers. Everybody does better. But for ours, with slight to mild hearing losses that can fluctuate over time, what's the downside? Well, the downside is that they don't often occur regularly in classrooms. They're often advocated for by parents, which is maybe a plug for us here. They can be personally obtained, like the Phonak systems. And I've had children this is an old system of this here, and this could actually be moved from classroom to classroom, actually. So you can actually do personal benefits to not only your own child, but probably benefit everybody else in the classroom as well. You can also project these to individual hearing aids themselves, if tolerable, and you can also project signaling from the speaker to that of personal headphones or personally installed speakers, like something like this. So this is actually nice, and I probably would drive home my point here as a home run is, remember the data that I showed you earlier about the speech perception of the 10 Down children pointing to a picture in the various levels of noise? What do you think happened when sound field was introduced into that environment? That's what happened. They do better. They stay on task better. They focus better because they're not making cognitive guesses as to what is being said perhaps in the environment. I'd be amiss if I didn't mention cochlear implants just because 2 patients of ours that did have the profound hearing loss did receive cochlear implants, with a third that was attempting to kind of assess the eligibility for that use. There was benefit from the 2 with the cochlear implants. Eligibility is unique. It has relaxed a lot over the last, shall I say, even 5 years. But again, reserved more so for the severe to the profound hearing loss. But cochlear implant certainly has changed the face of deafness. And cochlear implants is just that. It's an implant within the cochlea by electrode that stimulates the auditory nerve directly. So really quick on summaries. Oops, wrong way. Summary, testing can be difficult, but persistence and compassion is needed. It's a very heterogeneous group, but largely that of a slight to mild hearing loss due to ear infections that fluctuate over time. And then significant abnormal middle ear and eardrum functions, largely due to those infections, and could or would benefit from amplification. I think absolutely, largely from such sound field amplification that we have here. Absolutely consider annual audiometric evaluations because most of our children cannot self-advocate for the fact that they're having hearing difficulties. And they're probably not even advocating for the fact that they might even have an ear infection. So annual evaluation is absolutely critical. Lastly, I'm just going to end with the fact that, you know what, there's a difference between hearing perception and hearing processing. Hearing processing is a very different animal. And it's very difficult sometimes to get a hold of that. There are processing difficulties. Just because you can hear normally doesn't necessarily mean you process normally. And that's been reported in, dare I say, some cohorts of autism. So how you process sound is different than how you receive sound. What we're talking about here is the reception, the better reception of sound. But first thing you have to do is receive it, and then we can work on the processing. So with that, I'm just going to end with a couple of resources that are provided on the slides that you'll be able to download as well. And then thank you. And I took all the time. In fact, I stole a couple of minutes from your lunch, which I apologize for. But I am available either for questions now or for questions during lunch or a little bit later, I'm believing, at about 3 o'clock today. Thank you again. Thank you again.
Thank you to Chris. We'll take one question and then it's off to lunch. I'll say that Chris Zalewski's been one of my favorite people to talk to at this conference during the breaks, and so I bet he'll talk to you during the break as well.
Okay, quick question, and that is, when there's a middle ear infection, does it typically impact the high frequency hearing, or is it broadband across, all the way across?
Initially, if it's just a really acute infection, it tends to affect the low frequencies and somewhat of the mid frequencies. The more recurrent they are, the more generalized it becomes across the hearing frequency range, which, of course, for us, it's more of a recurrent nature and possible. So I would probably generalize the comment, which I don't tend to do that often, but say at least for the Smith-Lemli-Opitz group, it would be more of a generalized effect across most of the frequencies.
Thank you, Chris Zalewski.
Appreciate it.